Hello, my name is Hallie Potter, and in this video I'm going to be discussing my direct care experience practice project that was implemented during Nursing 4604. Before I begin, I want you to think about a time that you were a patient in an emergency department. If you've never been a patient in an emergency department, I would like you to think about a time that maybe you were with a friend or a family member that was in the emergency department. Reflect on that experience, and while you do, I want you to think about how many times the nurse came into your room. How many times did they check on you? How many times did they update you with lab results or your plan of care? Did you feel that you were checked on enough? Did you feel that your needs were met? My idea for this project came when I was reading experience feedback from patients in the emergency department. Weekly in the emergency department where I work at Sarah Bush Lincoln in Mattoon, we are given patient comments and feedback to go over and read. Most of the time, they are positive, and it gives nurses an opportunity to be recognized for their hard work. However, in the weeks leading up to this project, I noticed a trend. I noticed that a lot of patients were expressing that their needs were not met. Patients were sending in comments like, "I was never checked on," or "I never saw the nurse." And I was really shocked when I saw the comments. How could a patient never see the nurse when they were in the emergency department? How could a patient say they never saw the doctor when they were in the emergency department, unless they left to their own will? As I began to reflect and put myself in the patient's shoes, it's then that I realized that we don't have a rounding policy within the emergency department at Sarah Bush Lincoln. However many times the nurse enters the patient's room is up to their discretion. So if the nurse only entered the patient's room to give medications or provide tasks that populated from the patient's electronic medical record, then those are the only times that the nurse entered. If the nurse did not feel the need to enter the patient's room and update them on lab results or the plan of care, then it probably didn't occur. Additionally, we do not have a place where the nurse can document that they went in the patient's room and rounded on the patient. There is hourly rounding documentation that can be accessed through the patient's medical record, but it was difficult to find and difficult to get to. I quickly realized that patients that were saying that they were never checked on, patients saying they never saw the nurse, very well could have never seen the nurse and never be checked on. When I was looking through policies that we have, I noticed that the emergency department does not have an hourly rounding policy. We do have policies about how often vital signs should be obtained in those that are acutely or critically ill based off of their triage level, but we do not have an hourly rounding policy. This is different compared to other floors within the hospital. The ICU, progressive care unit, floors, medical surgical floors like 4 East and 4 West, all have specific policies that state that patients are to be rounded on each hour, and it's a task that is split between patient care technicians and nurses. It's a shared responsibility, but the emergency department does not utilize this. So I made it my mission to implement a new hourly rounding policy within the emergency department, and my hope was that if nurses began to hourly round on patients and assess and evaluate their patients on a more frequent basis, that these patient satisfaction scores would go up via the Press Ganey survey that's administered to the patients that are discharged from the ER, and that we would begin to see more positive feedback and more positive comments about patients being checked on, evaluated, and assessed. After I did some research, I did notice that there is a strong correlation between hourly rounding and patient satisfaction. Specifically, patients' perception of their care is influenced by how often they are seen, assessed, evaluated by the nurse. So, for instance, a nurse like myself could go in the patient's room and provide exceptional care and care that is correct. Meds could be administered on time, all tasks could be completed in a timely manner. But if the patient perceives that they were not cared for, then their perception becomes their reality. Patients don't always know what is going on behind the scenes and what we're working on as nurses. And that's understandable. It's a very busy field, especially in the emergency department, where we can experience a lot of intense situations. But if you put yourself in the patient's shoes and you realize that they're sitting behind a closed door and don't realize what you are doing, hourly rounding makes all the difference. Just to even go into the patient's room, even when they don't need anything, and just let them know that you are there, changes their perception of the care that is being received by them, thus changing what they put through their patient survey and if they were satisfied with their care. I implemented an hourly rounding policy first by creating a rounding policy since we didn't have one. Policies within my workplace are created first, but anybody can create a new policy if they wish to. They must present it in an SBAR communication format, situation, background, assessment, and recommendation, and then that is presented to your administrator, manager, or director. I chose to sit down with all three, my administrator, manager, and director, and I presented this new policy to them. The policy just states that the nurses in the emergency department, as well as patient care technicians, are to complete hourly rounding on patients, whether that is shared between the two of them, alternating hours to make sure that it's completed during their stay, or just that it's completed either by the nurse or the tech. We now had a policy written and drafted by myself that could be implemented to implement hourly rounding. Once I discussed it with them and got their approval, I then began to implement the actual task of hourly rounding. That was a roadblock that I hit. I realized that even though hourly rounding is present within the patient's electronic medical record, it is very difficult to get to, and that's one of the main reasons that nurses provided pushback on the specific topic. There is not a task that populates every hour for the nurse to complete, whereas vital signs populates hourly for the nurse to complete, sometimes sooner if the patient is more acutely ill, and was a good reminder for the nurse to complete it. Hourly rounding does not populate at all as a task for the nurse to complete. It's simply something that they have to remember, which is extremely hard when you have a large patient load in very critical patients. So I talked to the IS department and had them create a task that would populate hourly within the patient's electronic medical record that the nurse or tech could click on and then document what type of rounding was provided to the patient, whether that's toileting, a warm blanket, positioning for comfort, etc. Because that is also one of the biggest difficulties with hourly rounding is that a nurse may say that they did complete the rounding, but there is no documentation to back it up. And we all know that we are only as good as our documentation. If you didn't document it, it wasn't done. So these patients that were sending in comments saying, I was never checked on, the nurse was never in my room, there was no proof that the nurse was in their room aside from maybe a medication administration or care task that was completed. So it was imperative that the nurse have documentation to back up their rounding. So not only could we show for quality measures that the patient was rounded on, but if we had a poor experience with a patient and we followed up with them about that poor experience, we could back that up with the nurse's rounding and tell the patient, here we have that the nurse had gone in your room at these various times. After this new task was implemented, I met with our patient care leaders, or PCLs, that are on the floor within the emergency department. Their job is just to make sure that all nurses are completing their tasks and are just a helping hand, as well as the charge nurses. So charge nurses and PCLs I met with together, and I discussed the new hourly rounding policy and how it was to be completed, as well as showed them how the task populates hourly to be completed. The charge nurses and the PCLs really are the lead example of nurse in the emergency department. So having them as a stakeholder and having them on board with the project was essential. I needed them because I could not go around educating each and every nurse myself and each and every patient care technician myself. So having these individuals also be on board with my plan meant that they could remind nurses throughout the day, hey, make sure that you're completing your hourly rounding. Not only this, but they could also round on the patients and document it. If a nurse was busy, they could contribute to making sure that the task was completed. Once I met with them, I also created a task that could be assigned through patient education. We call them OLLIs where we work. Or sorry, not patient education, but employee education. An employee education task that could be assigned through work OLLIs that employees could complete to show that they were competent with the new hourly rounding. We have over 160 employees within our emergency department. Meeting with each and every single one of them and ensuring that we are meeting with every one of them is nearly impossible. It's very time consuming as well. So by creating a task that employees could complete with their employee education meant that I could see and know that all employees were educated in the topic of hourly rounding and that there wouldn't be an excuse for it to not be performed and employees to not know about this new task. Since we now had a new policy and the documentation to back it up, we were able to correlate the patient surveys and patient comments that were coming back with hourly rounding. And that was one of the most important things. When you make a goal, when you implement a new task or a new policy, how are you going to measure outcomes? We always talk about this. We need measurable outcomes when we implement new ideas in nursing. So the fact that we had it now within documentation made it able to be audited through chart auditing and quality control. So when patient satisfaction or patient comments came back through their surveys, for instance, if the patient's comments were poor, could we look and see in their chart and see if they were rounded on less frequently? Is that why they had a bad experience? Patients that had comments that came back that their care was exceptional, we could correlate with they received rounding every hour and were checked on and perceived that their care was good. In the end, we were able to correlate that patient satisfaction does improve with the implementation of hourly rounding, especially within the emergency department. And not only that, but the quality of care and patient safety also increases when hourly rounding is implemented. If you're a nurse, you know that not always when you go in to round on a patient or check on a patient, do you perform the task that you thought you would. If you thought that you were just going to provide a warm blanket for a patient during your hourly round, but you noticed that their bed rails were down, it provides you an opportunity to fix that situation. Maybe you rounded on a patient to offer them toileting and prevented them from getting up on their own, thus preventing a fall. And in my paper, you will see that there is research to back this up. And that's the evidence that I provided in my paper, talking about how not only is there strong correlation between patient satisfaction increasing because their perception of care increases, but also lots of good catches, lots of increased patient safety and patient quality of care from hourly rounding. I'm very proud of this project. I'm very happy with how it turned out and how I was able to implement something good within my department that is going to continue to increase patient satisfaction long after I'm gone and long after I've gone to, advance my career or do something else. And all in all, I really found that change is possible from anybody. It does not matter your job title or status within a certain department. If you see something, you should say something and try to implement something. We can all make our workplace a better place. And I really hope you enjoy reading through my project and seeing the work that was put into it. Thank you.